first speaker for this panel is revisiting Michigan. He's been with us at this event before. Shaun Alfreds is the Chief Operating Officer of Health InfoNet, which is the statewide health information exchange for Maine. At Health InfoNet, Shaun oversees strategic and operational activities of the organization, including the client services, programs, grants, finance, and human resources. We should have just listed the things you don't do. That would have been shorter. So over the past 15 years, Shaun has directed their consulting, research, policy development. He also holds a faculty appointment in the Department of Family Medicine and Community Health at UMass Medical School, and is a member of the Board of Strategic Advisors of the Health Delivery Institute at Worcester Polytech, and received his MBA from the University of Maine. So, Shaun, we'd like to welcome you, and thank you for coming.
Thank you, Jeff. Thank you all. I'm really excited to be here today. It's really fun to come to another state and hear what's happening and all the great things that are happening. I'm used to getting up here and talking about health information exchange, and I'm going to be talking more about SIM today. What's really fun is I can start the exact same way. You've seen one state health innovation project. You've seen one state health innovation project. So what I thought I'd do today is just kind of talk a little bit about what our state innovation model looks like in Maine. As Jeff mentioned, we are around one state, so we're about halfway through. And we've had a lot of great work that's been done across our entire state, and have a lot more work to do. But hopefully, you know, some of the things that we're bringing to the table might be helpful to you as you're thinking about now the implementation phase of $60 million. The slide, how do I change the slides?
Someone has taken it. Oh boy. Here we go.
Oh, there we go.
It's hidden.
Great. All right. So I'll start by saying that I'm not representing state government here. These slides did come from my state government partners, though. So any errors on the slides are their fault. But all joking aside, our innovation model was a fairly grand idea when we applied for this in round one. And in the round one applications, there wasn't a lot of information on how this money could be used. CMMI released the funding opportunity announcement, and we just all got together and said, okay, so what are we going to do? And we came up with quite a few projects. Actually, we have over 350 different projects going on in our grant. We were awarded $34 million over 3 years to do quite a bit in the state of Maine, with the laudable goal of getting 80% of the payments transitioned from fee-for-service to an alternative within 5 years, which is quite a bit of work, considering our state today is about 85% fee-for-service. Unlike you all here, which was helpful for me to hear this morning, we don't have much managed care going on in the state now. So there's a lot of transitions from that perspective as well. For our SIM grant, we really tried to focus on 6 what we call pillars now: strengthening primary care, integrating physical and behavioral health, developing our workforce across the healthcare continuum, looking at and developing and refining new payment models, centralizing data and analytics, and engaging people in their communities. As with every big grant, you have to have that one slide that has it all. That's it. Don't strain your eyes, because I'll go over the details in other slides. But we were tasked early on to explain to the broader healthcare community in Maine what the heck this SIM grant is. And so this slide sort of represents it, with a mission, a vision, our strategy, our innovations, and our goals. When we got started, our goals were fairly lofty. We were going to bring down the total cost of care in Maine to the national average. We've traditionally sat above the national average for many years now. And there's multiple reasons for that. Improving the health of the population in at least 4 disease categories, and reducing prevalence in those 4 disease categories. Improving patient experience, and in both improving the measurement of patient experience and also the ultimate experience scores as being measured. Those were our goals at the beginning. Now we have a goal set that's probably 4 or 5 slides long in this font. But that focus is really important for us. We leverage SIM to really focus on the areas of health reform that had already been targeted in the state, which is really around that patient-centered medical home model, expanding patient-centered medical home, but expanding that in such a manner that it was integrated and coordinated with the rest of the care teams in the state. So that was our first pillar. And what we're doing is, and the way in which our SIM grant was structured is that, and I'll talk about this later, we sort of came out of the gate with 3 partners, well, 4 partners actually, the state of Maine, the state government, with Medicaid and the Department of Public Health as the primary drivers in state government. We had the Health Information Exchange, my organization, Health InfoNet. We had our quality improvement organization named Quality Counts. And then we had the Maine Health Management Coalition, which is a coalition of our large employers in the state whose mission it is to do public reporting on healthcare cost and quality and to help employers and people in the state understand quality and cost. And with those 4 partners, we developed a strategy when we applied for the grant and multiple innovative projects to bring forward underneath that umbrella of the SIM project. So within the primary care side, all of those partners are working at different levels. Our quality improvement organization is really focused on creating what we're calling learning collaboratives around the state, whereby there's statewide as well as actually boots on the ground quality improvement specialists being put into practices to help our practices and help our primary care providers implement patient-centered medical home, understand what it means, help them understand everything from the actual administration of the patient-centered medical home model all the way out to understanding how to manage this from a payment perspective with our public and our private payers. On the Health Information Exchange side, our work here was around making sure that we were connected in that space as much as we possibly were. So today there are 175 patient-centered medical home practices. I believe we have bi-directional connections to 150 of them, and that's growing. We also have View connection, which means that they can access our Health Information Exchange portal in all those sites. That allows us to also bring forward ADT notifications, which is admission, discharge, and transfer notifications, so that when patients that belong to that practice have a transition of care, whether it's a admission or discharge from an inpatient or emergency department, whether it's a discharge from a long-term care facility in the state, or whether it's a multitude of other things like final lab results are available, radiology results available, that information gets sent directly to the practices in near real time. We also are doing notifications to the Maine Care program. And this was a fairly large change within our state. Our Health Information Exchange is very provider-centric, which means that we don't have any participants as payers today. And so our SIM grant focused on bringing the payer in. And what that meant was, we had to renegotiate all of our participant and data use agreements. Right now we have about 475 different entities connected to us. And so adding that payer concept into our legal framework for data sharing was not insignificant. And then building the mechanisms to share appropriately with the Medicaid program. As of today, we've taken in 4 years of longitudinal, fully identified claims data from Medicaid, and we're incorporating that into our data set. And we're sending Medicaid PHI notifications. So with our ADT notifications on the provider community side, we send them a notification in their open email, and it's not a secure email. It just sends a notification that says patient medical record number XYZ had a visit, click here, and we have them log into the exchange so they can see the full record. On the Medicaid side, the reality is that the patients didn't give Medicaid permission to see their full longitudinal record. Medicaid can only see the record for that patient for the services that they've paid for. So we built a PHI notification where we could actually send the discharge summary, we could send the ADT information, we could send the ED report and the other documents that are attributable to that visit to the Medicaid care management team, which is fairly small, but they're focused on their high-risk, high-cost individuals. So that's been built and is now functional. They receive basically weekly lists from us of the patients that have had events and the clinical information attributable to those events. And then finally, we're pushing more data down to the practice. Our Health Management Coalition is putting together what we call as practice reports, which are retrospective reports on the quality and cost of care delivered to patients attributable to those practices. And we're as part of our learning collaboratives, we're providing education to those practices on how to use that data and translate that data into information. On the integration of physical and behavioral health, a big focus for us. We have a new delivery model that's being implemented within the Medicaid program. So a behavioral health home model. It mirrors the patient-centered medical home work out of the Medicaid, but it's focused on the behavioral health agencies and gives incentives and a change payment model coming out of the Medicaid program. We also had a major health IT initiative targeted to behavioral health, whereby we provided incentives to the behavioral health agencies that were participating to adopt electronic health records and connect to the exchange. So we used our SIM dollars to bring about $1.4 million back to the behavioral health community to help them buy the interfaces they need to connect to the exchange, to support the legal costs of understanding the frameworks in which they have to work within and negotiate within when they're thinking about not only sharing behavioral health records, but also what does that mean for the 42 CFR substance use records, and how do they deal with that internally. It was also money to help them internally to just manage the networking costs, et cetera. So we have 20 behavioral health agencies that are receiving those incentives, and they're being paid out as they meet milestones. The first incentive payment goes out when they sign the contract, the legal contract to share data. The second incentive goes out when they connect to the exchange. And then the third incentive goes out to them when they actually start measuring quality with the data that they're exchanging with the exchange. And then finally, we have learning collaboratives that are being set up, actually that have been set up, that mirror what's happening in the primary care space with the behavioral health community. On the third pillar, payment models, clearly we have a lot of folks at the table. I'll talk about our governance in a second, but our view here is to promote public-private partnerships to help better inform the provider and the payer community about what's happening and create alignment for new payment models. So I sit on the SIM steering committee. Much of our conversation on the steering committee is really about how do we align incentives, how do we align measures to make it easier for everyone to get information and to hold each other accountable. We have VBID, or value-based insurance design, work going on across the state through multiple work groups, multi-stakeholder work groups that are set up across the state to look at value-based insurance design. We have a co-op in our state, so the co-op is involved, as well as the commercial and private, commercial and public insurers. And then we also use those practice reports to help inform the practices on what this means from a practice management perspective. On the workforce side, we're doing a lot on leadership development. We have a leadership development process that's been set up where physicians and clinicians around the state can apply to get free leadership training, and a lot of it's around change management in this case, understanding how to deal with all these changes that are coming down the pike. We have community health workers that are being deployed out through our public health program to really focus on your core chronic diseases, diabetes being the top one. And then we have curriculum that's being developed for integrated team members so that they can understand, so that behavioral health providers can understand what integration really means, to help them understand what's happening on the other side, and vice versa. Helping the behavioral health provider understand how to manage chronic conditions, helping the primary care provider understand how to manage and work with a patient that has a behavioral health provider and is working with that behavioral health provider on those issues. And then centralizing data analysis, we have a ton of work here. One of the biggest challenges in Maine, I think, is that we have too much data sometimes. We have the exchange. We have lots of clinical data in the exchange. We have 100% of the hospitals participating. We've got about 80% of the primary care workforce bidirectionally participating, and about 20% of specialty. It's a lot of data. We also have an all-payer claims database, which has de-identified data from every single insurer going back to 1996. And then we have our Health Management Coalition, who is doing work with all of our large employers, who has built another fully identified claims database to help those employers understand what's happening with their rates, understanding what's happening with patient quality from the employment side. So we have all this data going around. And so part of our work in SIM, and we struggle with this still, is defining how do we take this rich data resource and A, turn it into information that's usable and actionable, B, implement it in such a way that actually it makes sense for the workflow that we're pushing the data into. Clearly, right now, our physician community has to go to 3 different portals to access information. They've got a Medicaid-based portal to look at the Medicaid membership and enrollment. They've got the Health Information Exchange. They're getting practice reports from the Maine Health Management Coalition. It's daunting. And then we also have PQRS measures, HEDIS measures that are also being reported out, and they're not aligned. So a lot of our work is on alignment, and we have a lot more work to do there. We are doing public reporting on quality and cost now with that data, so that's helping us inform the community. We're developing dashboards for the provider community to help them and monitor trends. That's that practice report. We're also starting to do that on the HIE side too. And we're also merging clinical and claims data. So on the HIE side, we've taken in that claims data, we've merged that claims data with our HIE data, and what we're doing is we're doing predictive modeling. Going back to the conversation this morning, we're doing big data analytics on this to help to better predict your high-cost membership. Right now in our Medicaid program, it's a very manual process. When a new membership comes in, they're seeking out information on these new members that they know nothing about. Here now, we're able to leverage that information, provide the Medicaid agency with risk scores on new members. For the first time to help them identify which ones they should be targeting for case management and care management. We're also doing that and using those risk scores back on the HIE side. By the HIE, while we have lots of clinical data longitudinally, we don't have everybody. We don't have a lot of like this the ancillary care, chiropractic care. Our ambulatory side, we only have about 20% of specialty. That's a problem. And so what we're able to do with that claims data is we're able to bring that in and fill in gaps in our data sets, which helps us generate better risk models that we're now providing back out to the provider community. And we've seen noticeable increases, statistically significant increases on our sensitivity rates, which means we're identifying more people at risk so that can be targeted for case management and care management. Engaging people in communities, clearly this has to be part of what we're doing. I'd say we're doing an okay job. We can always do better. But we're implementing the National Diabetes Program statewide. We've got a community health worker program where the departments of public health and the local public health departments in our cities are deploying community health workers into the community to target high-risk individuals. We're educating consumers on what to expect from this model of care, so we're holding forums statewide for consumers to help them understand health reform. And we actually just finished a pilot. Now we're talking about rolling it out statewide, where we've provided patients with access to their HIE record. So using the blue button standards of the VA, we were able to work with our provider community in one of our largest integrated delivery networks to give patients a blue button, essentially, within their EMR-based patient portal. And patients within 3 practices was the pilot, were able to download their HIE record and use that in conversations with the provider that they're seeing. We had, within a 6-month pilot, we had over 350 patients download that record, and most of them came back more than once. And now we're talking to the system about how we're going to now take this and roll it out statewide. This is our governance model. I think for SIM right now, our successes are based on involvement of multiple stakeholders. This is not a public effort. It's a public-private partnership. We do have the governor's office is highly involved in the project. The governor's office is the applicant on the grant. And we have a leadership team within state government that involves our commissioner level staff, our commissioner of health and human services, our commissioner of insurance and finance, as well as our directorship of the Medicaid and public health programs. And then we have a steering committee. The steering committee is made up of the partners. I sit on the steering committee, Maine Quality Counts, Maine Health Management Coalition sit on the steering committee. But then it's made up of the provider community. So we have hospital representation. We have primary care representation. We have specialty representation. We have payer, commercial representation, sitting around the table to talk about both the projects that are underway, but also how are we going to sustain these efforts? How are we going to learn from them? What data are we taking in to analyze, to understand impact? How do we course correct when we're seeing we're not getting the expected impact on some of these projects? And then below them, in reporting to the steering committee, we have 4 subcommittees. One on payment reform involving the community, these subcommittees. 50+ members of the community, huge involvement by the community on all these subcommittees. People want to come, they want to be involved. Delivery system reform, same thing. Data infrastructure and evaluation. So what have we learned so far? We're a year and a half in, and we probably spent the first 6 months of this project dealing with that last slide, governance. That was a really hard part. How do we engage people and engage communities and stakeholders in a way that's meaningful? One of the things that I think if we had hindsight, we wouldn't have allocated all of the grant to the existing projects. We would have left it open so that we had more opportunity to actually engage payers, the private payer community, because that's been a challenge for us, because we've asked them to come and have a seat at the table, but we're not giving, the grant isn't really focused on the alignment as much as it should be with the private payer community, because there's so much of a focus on the Medicaid and the Medicare side. It's about getting that and providing resources out so that there's some skin in the game and opportunity for involvement in actually steering the boat. Leadership at the table. One of the things that we have found early on is that we need decision makers at the table. Sometimes with these grants, you ask, and you're all familiar with this, in the healthcare community, we all are very, very busy. And so, you know, I get in my email, hey, Shaun, can you participate on this committee, that committee, that committee? And oftentimes I won't have time, but I'll assign staff. And the challenge with that is that in something as big as this, we need decision makers at the table. We need people who actually have decision-making authority, so that as we're talking about major initiatives, we're able to bring them in. Multi-payer, I talked about that, but it's so important, is really the alignment piece. You know, getting the alignment of all the payers at the table is critical for our success. Predetermined outcome, I think I talked about that in a way. We said, these are the projects that we're going to do. We got CMS to fund it, then we went down the path. The problem is that we didn't give ourselves enough flexibility. Specificity, critical. We totally underestimated the amount of project management that goes into something like this. 350 projects, $34 million, 3 years. I can't even count how many stakeholders. So project management resources were totally under budgeted. So as you're thinking about that here, make sure you're really focused on that. So I mean, and then finally, I think importantly for us, and I think importantly as you embark on this, working with CMMI is a challenge, and you'll find that out. But at the end of the day, this is about implementing and getting money to implement something that you want to sustain. So think about the business case now. Don't think about the business case later. Because if you're not implementing something that has a business driver, it's just going to be funded and then it's going to die. So for us, those are some lessons that we've got to date. Don't wait for Medicare. It's a slow-moving ship. So I'll stop there, and we'll open up for questions later. Thanks,
Thank you, Shaun. So that was Shaun just on SIM. Many of you have said very nice things about our progress here in Michigan today. Thank you. But if you want to hear about a state that really has it going on in HIE, come back tomorrow afternoon at 1:15 to hear Shaun talk about Health InfoNet. They have got it going on. So next on our panel is Lisa Moon, who is the principal consultant for Advocates Consulting, located in Minnesota. And this is Lisa's second visit to this conference. Thanks for coming back. Prior, Lisa worked for the state of Minnesota as the director of eHealth Privacy and Security and Health Information Exchange. Her team was responsible for coordinating the activities of the SIM grant round one. So she is also a legal nurse consultant, a board certified case manager, and has worked in both acute care and public health. She lives in the Twin Cities and is completing her nursing informatics PhD at the University of Gophers. I'm sorry, misprint, University of Minnesota. Just slipped, I'm sorry. And Lisa, welcome back. I hope you'll come back next year too.
I know I'm in the home of green and white, but I am a U of M grad, but I went to the Flint campus, so yes. So I'll be a blue and gold and a maize and maroon, so I'll have 4 colors when I get done. I really want to, first of all, thank the committee for asking me to come back. A lot happens in a year on a project as big as SIM, and I think that this is just a great time to come back and just kind of talk about not only lessons learned, but opportunities. And Shaun did a great job going over a lot of the very specific kind of rules around this project. And so I won't spend a ton of time on a lot of the specifics, because I'd like to get to a couple of the really great things that are going on now that SIM has actually been implemented and is moving. So like Maine, the Minnesota SIM, actually we renamed our project to the Minnesota Accountable Health Model. And it definitely is a joint project. It's between our Department of Health, where I did work for 3 years, and our Department of Human Services, which is for Minnesota was actually groundbreaking. They had never done a project together. So talk about cultural change, and it's been really good for us. It was a $45.2 million project, and it's projected actually to save $111 million over the life of this 3-year project, and we're already almost there, which is great news. It did actually expand our Medicaid ACO work that we had into projects that are now called integrated health partnerships. And what's new about this initiative and what SIM has enabled us to do is actually to start getting our claims data, the Medicaid claims data from our all payers claim database, out to communities who are now these ACOs, so that they can start actually understanding their populations from the claims data perspective. And of course, that's only one perspective. You need the clinical data, but it does give you better information about the people that you're actually managing. The other part is that we definitely in the demonstration used the multi-payer approach. And then we're also really leveraging health information exchange, which a year ago I talked about, and I don't know how many of you were here at the time, but Minnesota does not have one HIE. As a matter of fact, we have a very different regulated system where every health information exchange service provider has to become state certified. You have to actually have a certificate of authority. So it's a very decentralized model, which makes it complex. And so we have actually been pushing money out to the communities to help with connecting them up. The broad goals of the Minnesota Accountable Care model are really fairly similar to Maine's, that they establish these accountable communities for health. We also did, as I said, expanded the ACOs, but we actually leveraged that multi-payer approach within the testing so that we could get from the fee-based to value-based care. And we're also really working to align those incentives so that across the board, the quality measures and the incentives look more similar than different, which is really a big deal. And then we also are supporting our providers, obviously, with health information technology, but more importantly, we're trying to help them learn about how to use data in clinical practice, and so that's the data analytics piece. This is a list, it's kind of a laundry list of some of the projects. This is not all the projects, but it gives you kind of the bucket list of where we actually put the money. And I won't go through all of them. Many of them are actually similar to Maine. And I think that the important piece of this is that this is really a community-based project. So we really intended from the very beginning when we started even putting the proposal together, not to keep the money up at the state government, but to get money down into the communities so that people where they live could actually be affected. Doing that, though, starts to complicate things because you do end up with a lot of projects, a lot of communities determining what their focus is, their target is, and then it's a lot of project management, which Shaun already alluded to. I thought it's just interesting just to kind of take a look, because when you get, you know, kind of the pot of money that comes in, to see where it actually goes to. And so this is just kind of a nice overview. So you can see that most of the money for SIM within Minnesota, the state agencies determined that it would go out to communities within all of these classifications. So Minnesota, I can't make the mitten for it, but it actually is mostly rural. And the population is most dense in the Twin Cities, which you can see is kind of in the crook there. So what we determined with the SIM money, though, was that it could not just stay in the urban center. And even though we have a high population base there, and it's really important, we have some really, really critical needs around homelessness and social determinants of health, and we do have projects within our SIM funding that really look at those needs. We also knew that rural health was a big issue for us, and so the monies have actually gone out within grants, and we've had multiple awardees, and this actually shows you where they are. I thought I'd give you at least one example. And I'm actually working on this particular project now that I left the state, and it's 12 counties. It's in southwest Minnesota, and it is primarily rural. They only have critical access hospitals. They have a couple primary care provider networks. They have some really great collaborations between counties there. And so all the county boards came together 2 years ago and determined that they were actually going to come together, form a governance structure, and then they were going to choose a health information exchange vendor who would start connecting them so that they could become interoperable. And as you can imagine, 12 counties trying to come together, they tried to determine which population would they work on first. Well, this the Minnesota Accountable Health Model allowed them to become an integrated health partnership, and so they were part of the expansion of Medicaid. And so they're actually managing now about 24,000 Medicaid recipients out in those 12 counties. So some of the work that I'm currently doing with them is actually trying to set up a care coordination system, one that integrates health across all the domains of the care continuum, and actually uses HIE. And so we're actually looking, for instance, at how can we actually get a care plan that can actually be used by all 12 counties, regardless of the service organization that you work for. So it's interesting work, but it's tedious work. And as you can imagine, with all the privacy laws and security laws and issues with access and authorization and permissions, it's a challenge, but it's really great work, and it's work that the SIM grant funding has helped us to move forward. Grant activities for 2015 continue because we still have about a year and a half left. And so the most recent grant that's being awarded now is around data analytics, and that is really trying to help communities figure out how to understand their data for their community. Most of this is, again, around the integrated health partnerships, so that expansion of the Medicaid population. But when you get data out in a community that's rural, you really do not have a workforce that understands how to use the numbers, how to use the output, how to actually even sometimes sort a report. And so it's really important for us to be able to get the help out to those communities, because those communities take care of a lot of people. We might think of them as just rural space, but they actually have a high population density in some areas. We're also working on a second round of HIE grants, as well as practice transformation grants, which are just $20,000 grants. They're out to communities, but communities can determine what they want to do around transforming care. And it's mostly primary care and behavioral health or mental health that's receiving those. Our privacy, security, and consent management grant was awarded this year, and so we're actually starting that work. It begins with a legal review. Minnesota is one of the most complex systems to work in, or states to work in, because of our consent law. And we've actually identified 13 laws that impact the way that we can actually exchange data. And so the legal review is going to help us understand at a more discrete level what those differences are. Because as all of us sit in this room, we understand that there's reality, and then there's also perception. And what we'd like to do in that project is actually dispel the perceptions, the bad myths, and actually get our data moving, which is most important. And then one project I'm not sure that other states are doing is really around developing e-health, HIE roadmaps. And this is around the 4 priority settings. And the roadmaps actually will help. They're actually basically a collaborative between state agencies and our stakeholders who are experts in the field. But for instance, local public health, we have about 50 people who are coming in to collaborate with state agencies to say, how do we get data moving for public health? And so it's just an interesting way to bring our stakeholders together, but to move us forward a little bit more. So over just maybe the next minute or two, and then I'll end, the strengths of our model, I think, are really that it does create community-based strategies, and it really is influencing or impacting care where patients live. And I think if I could leave anything with Michigan, I would leave that. I think it's really important for us to make sure that we're impacting the care where people receive the care. And it does address the issues of payment reform. And sometimes we think about payment reform, we think, oh, federal government, state agency, we think big. We actually determined that we would bring the payers in, and that, you know, some of the, well, I would say most of the payers probably have some of the best and brightest minds in the country. They're forward thinking, they're thought leaders, and so we determined early on that we would leverage you know, a lot of that sophisticated understanding of the healthcare system. And so we're actually bringing them in, and we partnered with them. And then, of course, we paid deliberate attention to the HIT and HIE needs. And then we also encourage capacity building so that at the community level, you know, where care takes place, that we actually have enough care so that team-based care could happen, because that's a real problem, especially out in rural spaces. And then the one thing I'll spend my last minute on is the maturity matrix that we developed. It's the one piece that I think if I could, you know, give any advice to another state that's coming on to a project, it gave us actually a framework so that anyone who was applying for a grant, who wanted monies from the state innovation model, that they had actually had to do a self-evaluation and self-report out where they fell on a scale. And they actually, there was 7 different sections of this particular tool. The tool is available publicly on the internet through the Minnesota Department of Health and the Minnesota Health Reform website. But it takes these 7 domains and it really makes you think as an organization, where are we currently? So it gives you the current state. And then we're using this as an evaluation tool over time so that at the end of the project or at periods during your project, you're supposed to reevaluate yourself, because what you want to do is you want to see progress over time. And that's really important, because all of us get involved in our projects and what we're doing, and we think that we know where the ball is and we're not losing sight of it. This framework actually has really, it's been one of the things that our communities have appreciated most, because you think also, communities think, oh, we're so advanced, and then they look at a framework like this and they actually find out that they have a long way to go. But it also shows them or gives them some kind of vision for where the next steps are. So opportunities for improvement are really, our project ends in December of 2016 for that first round of grants, but I would just say standardize where possible. You know, try not to have too many projects. Try to do things that you can replicate in other parts of the state. And really, if you can leverage what you have for assets at the community level, I think that you'll go a lot further. Because ripping out and rebuilding, we've already spent an awful lot of money in healthcare, so I'm kind of against that. I think that we should, where the strengths are, we should be building on those, and that means community assets. And so I'll leave you with that, and I just want to say thank you for inviting me back.
Thank you very much, Lisa. Those are valuable lessons learned, and I think some of our folks are probably going to be rushing to download that matrix. Thank you. So rounding out and batting cleanup for our panel of speakers who hail from states that only begin with the letter M is Dr. Stephen Shaya. Stephen graduated from Birmingham Brother Rice, went on with many awards and scholarships to Wayne State, where he continued on as a member of their Board of Governors, and then attended their medical school, graduating in 1996. He subsequently finished his training at the family practice at North Oakland Medical Center and fellowship and things like that. And since 2004, Stephen has been the Chief Medical Officer at J&B Medical in Wixom, which is a global healthcare solutions company, and they have many different business lines in 48 states. They ship lots of medical supplies and other things. They have a telehealth solution. If you haven't seen it, it's very cool. I would suggest you see that. So Stephen is going to give us a different angle on the economic implications of healthcare. Stephen, welcome.
Well, first, I wanted to thank MiHIN for the opportunity and privilege to participate in this event today. Also wanted to thank Jeff and Tim. Every time I sit down with you guys, I feel like I'm getting continuing medical education on all the new and innovative things you guys are doing. Special thanks to General Granger. Every time you participate in something, you bring such great wisdom and insight, and you're such a blessing to our family. So thank you for participating in this. And finally, and most importantly, I'd like to thank my wife, Samantha, who's home with our 2 children. Baby Adele is 2 years old, and baby Grayson is 2 months old. And every time over the last few days I was practicing my talk, they actually fell asleep. One of the very rare, just a few of the very rare occasions they've actually slept the last 2 months. So my wife has a humble request that we get a copy of this talk today. So thank you. I am here today, as Jeff mentioned, to take a little bit of a different angle. J&B is, with our different business lines, we are one of the largest providers of medical products to the homes in the United States. So my comments today are really framed around the optics of a provider. Worldwide, technology and its promise have moved up the healthcare agenda. Steve Jobs says that innovation distinguishes between a leader and a follower. Disruption is occurring in many industries today. In 2015, Uber is one of the largest transportation companies, and they own no vehicles. Facebook is one of the largest popular media companies, and they create no content. Alibaba is one of the largest retailers, and they own no inventory. And Airbnb is one of the largest accommodation providers, and they own no real estate. Great providers and state-of-the-art facilities are not going to be enough anymore in healthcare. Access to information is going to be the enabling and disabling factor today. The big idea is there's no one big idea. In effect, there's no one magic bullet that's going to heroically resolve all of our challenges. And this has a lot of implications because we have a fractured healthcare system where a great deal of focus and energy has been spent on trying to disrupt the system, and just in the same way some of the aforementioned companies did in their industries. Healthcare is not immune to disruptive forces. The old model of healthcare was a very high-touch model. Someone would go to their doctor's office. Someone would go to the hospital. A healthcare professional would come to the home. Many people over the last several years have forecast a new paradigm would be a high-tech model. There are telemedicine, there's telehealth, there's video conferencing, there's mobile apps, there's sensors, there's encrypted emails, there's encrypted text. We are all going to live in a connected health environment. But there still needs to be someone coordinating care. With all this data and information that's being generated, someone needs to coordinate care. So the real model will be a hybrid model. It will be a combination of a high-touch and high-tech model. Health will be provided by technology-enabled services. And there's no one solution, there's no one gifted gadget or application that's going to bring about the transformational breakthrough. But it will be the data and information provided by a multitude of these solutions, along with technology-enabled care coordination, that's going to bring the next generation of healthcare. It's not the volume of the data that's going to matter, but it's the value of data and the ability to act. Even with all the complexities and fragmentations in our healthcare system today, the wave of disruption is coming. Henry J. Kaiser, the founder of Kaiser Permanente, said, "You can't sit on the lid of progress. If you do, you'll be blown to pieces." Every day, we create 2.5 quintiles bytes of data. 90% of the data today did not exist 2 years ago. I think Stephen Gould of IBM Watson had a great metaphor for data. He said that it's like fuel. In the ground, it has a certain value. When you take it out, and you start to refine it, you amplify its value and its usefulness. Big data usually refers to a combination of structured and unstructured data, and a lot of folks today have talked, in various forms of that, and it's measured in petabytes and exabytes, and it's often said to be characterized by the 3 V's: the volume of data, the variety of data, and the velocity at which it's processed. But these are all make it very challenging to manage. Small data, which you don't hear a lot of people talk about, is the data in a volume and format that makes it accessible, informative, and actionable. Data is too numeric today. We have too much of it. So data visualization tools will be critical for us to understand what all this data means. Moreover, 85% of our population learns best by pictures. I could tell you I do, and I could tell my daughter does today as well. Moreover, the timing of the data is going to be very important, and the actionable data needs to be received in a workflow that can affect your decision-making process. Hence, these are the discussions we've been having as a provider with MiHIN. Our company, our parent company, J&B, and HealthNet Connect, which is our virtual care company. How do we receive these ADTs, admission, discharge, and transfer alerts, to better coordinate care? I can tell you, as a provider today, when someone goes to the nursing home, we may not find out for a month or two, but we're still shipping them products, not because we want to, because we don't know. Unless they reach out to us, we don't know. And so working with MiHIN, we believe that just receiving the admission, discharge, and transfer information could play a very critical role in taking care coordination, not just for us, but for all the providers out there, and help us save the system a lot of money. As Jeff said earlier, someone's paying for this inefficiency. Maybe it's us, maybe it's the state, maybe it's the payers, but someone's paying. And we need to cut that inefficiency out of the system. The data market today is large and it's growing. Depending on whose numbers you believe, big data market today is about $32 billion and will be about $53 billion in 2017. Many project big data could save the U.S. healthcare system about $300 billion annually. 25 to 50 billion in better care coordination, 125 to 175 billion in mitigating the waste, the fraud, the abuse, 175 to 200 billion in better administrative and clinical efficiencies. The biggest benefit of big data is how it helps us act as a platform, in effect, to predict the future for patients, opening the door for more prevention. The traditional healthcare model has been detect and respond. The new model will be anticipate and prevent. I was just in La Jolla, California, and there was a longtime La Jolla resident, Theodore Seuss Giesel, that lived out there for many years. Many of you might know him as Dr. Seuss, and he had a Dr. Seuss-like quote that I think applied to big data. He said, "Oh, the things you can find if you don't stay behind." Once you have the data, it can be translated to information. This information can be leveraged in a variety of ways. General Granger talked earlier about precision medicine. Simply, we need to deliver the right care at the right time to the right patient at the right value. There are many challenges to go to where we need to go. Some of these challenges include interoperability, privacy, and reimbursement. Well, you folks know a lot about interoperability, but just some interesting statistics. According to the Department of Health and Human Services, 20% of preventable medical errors are caused by lack of immediate access to data and information from the medical records. 1 out of 7 primary care visits is impacted by missing medical information. We spend about $30 billion a year because of the interoperability challenges that we have. So I'm proud to say that MiHIN has really been a leader nationally in helping streamline these efforts. And believe me, when you go to other places, I appreciate MiHIN more and more every day, put it that way. Just with interoperability, an analogy that I thought was very apropos, Steve Jobs, many people think Steve Jobs was a great innovator. He was a genius. And you look at what he did with the iPod, and the MP3 technology was out there. Many people had the MP3 technology, but he made a cool-looking device. You press an icon, you are listening to music. He made the process simple and seamless. That's what we need to do in healthcare. Another critical barrier to success will be managing privacy issues. There are many pitfalls with patient health information that many of you have eloquently brought out. The answer to me here is simple. We need an opt-in approach. Patients are going to have to willingly choose to share their information. In a recent Intel Innovation Barometer study, published in December of 2013, 84% of the 12,000 respondents said that they would anonymously share their personal health information to advance and lower the cost of our healthcare system. We're going to all have to be more responsible and participatory in our healthcare. And then finally, the incentives are going to have to align with some of these innovative approaches. CMS has recently announced in March of this year that for the new ACOs, the next generation of ACOs, they are going to start, you're going to be more at risk, so there's going to be more savings, and they are also going to start paying for telemedicine in urban settings, and also remote patient monitoring. And we really believe that this will play a very big role in helping move the wave of innovation and disruption forward. Big data initiatives have the potential to transform healthcare. Stakeholders that are committed to innovation, willing to build their capabilities, and open to a new view of value will likely be the first to reap the rewards of big data and help patients achieve better outcomes. Jonas Salk said, "Hope lies in dreams, in imagination, and the courage of those who dare to make dreams a reality." Walt Disney said, "All of our dreams can come true if we have the courage to pursue them." My friends, if you dream about the next generation of healthcare in our country, better measuring, managing, and optimizing data and information will be the key to making this bold vision a reality. Thank you.
So when we prepared this panel, they asked me what would I like them to accomplish, and I said, just keep them awake after lunch. I think you can agree that we've done that. Stephen, I love your passion, and thanks for leaving time for Q&A as well. Thank you all. So we do have time for a few questions. I see one here, here, and here. So we're getting mics over. Oh.
Lisa, this question is for you. I know that Minnesota, like Michigan, has an active American Indian population, and I'm wondering how you worked with the Indian Health Bureau to make sure that that population was included.
Mike, please.
The Indian health population actually sits on 2 of the advisory steering committees, so that they actually have a voice at the table. We thought that that was actually one of the very first things that needed to be done. And then we made sure that when we're looking at the grants and reviewing the grants, that we actually were, I don't want to say that we gave priority, but we definitely looked at them to make sure that they were included within the funding.
There's one up front and one back here. We'll go back and then you next.
Yeah, question also for Lisa. Did the ACO certification process address the capital adequacy of those structures as they were taking full risk deals?
For the Medicaid population?
Yes.
I worked for the Department of Health, not for the Department of Human Services, where the ACO Medicaid expansion took place. But my understanding is that yes, they're all certified, including the fact that they have a data sharing agreement that allows the claims data to be shared with them. So I don't know if I'm answering your question, but they all had to be certified.
Jason Buxbaum with the Michigan Public Health Institute. Thank you all for your great presentations. My question is for Shaun and Lisa. I was wondering if you could speak a bit more to the nature of the alignment with commercial payers, and especially the extent to which the contract terms with the accountable care organizations were harmonized.
I'll start, and then I'll let Lisa take it on from her perspective. In Maine, at this point, you know, those are the discussions we're having now at the table, Jason. Right now for the SIM grant on the SIM side, it was really focused on creating Medicaid-based accountable care organizations. So there were 4 ACOs, Medicaid-focused ACOs, and then within the contracting process, there was a very deep and very focused contracting and award process for those ACOs. Now we're working to align it with the private payers and with the private ACOs, because we have about 9 private ACOs happening or involved at various stages in the state right now. But that's one of our challenges that I brought up is getting that conversation to the table at SIM. It's very political. You know, our health systems are cutting deals with the payers, and there is channeling happening. We see it. And so that's one of our challenges is trying to push for alignment when there is recognition that there is a business driver to channel those relationships.
Well, and I think that there was legal agreements, or there's legal requirements around too, what they can and cannot do with anti-kickback. So in Minnesota, and I'll just really quickly, we actually, one of our task forces was only the payers. We brought all the payers together and we just gave them one room, one voice, you know, one basically platform. And they actually are working with our Minnesota Community Measurement, which is our quality group, directly. So we've actually had them come together, and there's a direct intersection between both groups in their work.
So Dr. Jackson has a question, and then we have one in the middle, and I think that's all we'll have time for.
I'm president of SEMHI Family Doc, and if you know me, it's always this question. How are primary care physicians doing in relationship to their economics in Maine and Minnesota? Is that being monitored? And if not, you better get at that. Thanks. The question is it? And tell me about it.
So again, I'll start. Not well, frankly. What we see in the primary care community right now is a lot of movement towards joining the hospital systems. We see a lot of consolidation happening. Right now, about 80% of the primary care workforce is employed by a hospital system or an integrated delivery network in Maine, and we just see that increasing because, frankly, part of, you know, there's the economics of just getting paid, but there's also the extreme administrative burden that we're placing upon the primary care provider community for all the reporting requirements that we have in place, and it's a real challenge.
I think what's interesting is that when you start to look at the data that around patients and patient populations or subgroups, that you often find that primary care is important, but you see actually in a lot of our populations, the data I've looked at, that mental health actually starts to rise to the top. So I think in the new risk sharing or total cost of care arrangements that we have, what we've actually been learning is that we really have to have that behavioral health at the table to help take on some of the risk. And so that's where I would leave that.
Thank you. Last question here.
Dr. Fayyaz Syed with Michigan Primary Care Association. The question is for Shaun. Shaun, you were mentioning about the bidirectional exchange of information. My question is, how many different electronic medical records were you able to connect with? Was it just one, or did you have multiple electronic health records that were able to have that bidirectional flow of information?
So, quick follow-up. You mean on the behavioral health side or in general? In general, so we have 18 electronic medical record systems that we have bidirectional connections for now. Through the SIM grant, we're connecting 7 more, and that's on the behavioral health side. Frankly, those are some of our biggest challenges because the incentives for meaningful use have not driven standards into that community as much as it has in the hospital or primary care specialty workforce. But today, those are the numbers.
Thank you. Let's give it up for the M team.